Welcome back. As I mentioned in my intro, in the spring of 2012 is when I was awakened within myself and began a wrestling with my own historical spiritual wounds. It was a murderous rage that I had within me in seminary. I began working on it and I moved to Houston, Texas in 2013 to take CPE. My goal was to learn about pastoral care and then go back into the black church and elevate pastoral care in the black church, because I believed that we didn't do pastoral care. I believed we did pastoral parenting. That was my plan. Well, while I was in CPE in the fall of 2013, I met a woman while I was serving at Thomas Street, which is the oldest HIV/AIDS freestanding clinic in the nation. It was my first placement within the CPE program. And a woman called and left me a message. And I had spoken with her before, but her message said to me, "Chaplain, if you can help me to heal my broken spirit, I would be forever grateful." This was a woman with HIV, had it for 10 years, and now she's asking me to help her heal her broken spirit. And I did talk with her and discovered that her broken spirit had nothing to do with her HIV diagnosis. Some historical spiritual wounds in her family resulted in some different behavior that may have led to some things. But she wanted to go back and heal that original brokenness within her. I met another gentleman who was sitting on the couch, and I walked up to him one day and I said, "How are you doing? How are you coping with having HIV?" And he looks at me and he said, "HIV is the least of my worries." And after I picked my jaw up off the floor, I looked at him, and because I didn't understand. And he says, "I don't have a job. I don't have any money. I'm homeless. I'm living in my car, and I haven't seen my children in 2 years." He says, "But here at Thomas Street, I've got medicine. I've got people who care about me, who provide me snacks and food every now and then." He said, "HIV is the least of my worries." And then I was working at LBJ Hospital within Harris Health System. And we had an ethics committee meeting, a very difficult patient, challenging scenario of getting the patient discharged from the hospital. And in this ethics meeting, I've mentioned a few things and said a few things about my experience. I wasn't a staff chaplain. I was a CPE resident. But after the meeting was over, I had 4 people who came up to me: nurse case manager, social worker, and a couple of nurses. And they said to me directly, they said, "Chaplain, we didn't hear very much spiritual talk in there." And I didn't know what they were referring to. And I went and spoke with one of the lead chaplains, who mentioned to me that, "Well, we don't talk about those things in ethics committee. They don't really like that information. It kind of makes people nervous and edgy." But I got a sense that there were people who were yearning for that. And what the calling is of the chaplain is really to be the advocate, to be the voice of the voiceless, to be the voice for the patient and the family. And that's not what the nurses' roles were. That's not what the case managers' roles were. That's not what the social workers' role was. But they had a connection and a bond with that patient and that family that was a very difficult discharge. And they, as individual peoples, had a spiritual side, and they were wrestling and struggling. But it wasn't their role in that meeting to lift up that spiritual voice. Their job was to talk about the medical information, the social information, the discharge planning. But they wanted the patient's voice to be heard. They wanted to hear the chaplain's voice. They wanted to hear the spiritual talk and the family's needs. And so as I took all of this information from Thomas Street, from LBJ Hospital, and transversed into a second year of CPE, where you have to choose a discipline or a focus of your study, I chose wound care. Most people, when they do CPE a second year, they may choose trauma or oncology or cardiac. I chose to focus on wound care. And that's where began a 13-month observatory study of the skills and the verbiage and the practice of physical wound care therapists and how they provided inpatient and outpatient wound care. And my goal and my plan was to observe their wound care methodologies and then to translate that into a language and a model of spiritual wound care. Thus, spiritual wound care was birthed. I also chose wound care because wound care is personal. As I already said, all people have been, will be, or are wounded. So it's a personal experience that we all have with some form of woundedness, whether it be physical or spiritual, emotional or mental. All people have been, will be, or are wounded and have a personal experience. It was personal for me. It's universal. It's everyone. Woundedness does not discriminate. It does not alleviate. But everyone will find their time in a wounded experience. So it's universal. It's also theological. There's a theological nature to wound care because even God was wounded. 1 Samuel 15:11 says in the NIV translation, "And the word of the Lord came to Samuel and said, I am grieved that I ever made Saul king." Even God gets wounded. Isaiah says he was wounded for our transgressions, bruised for our iniquities. The chastisement of our peace was upon him, and by his stripes we are healed. There is a woundedness that even God has experienced. It's theological. And I believe that wounds and wound care is parallel and reflected. Because there is a connectedness in the soul, I believe that there is a parallel of how we can care for spiritual wounds by looking at how we care for physical wounds, because they're connected in the soul, and there's a reflectiveness that as I care for and tend to the wounds in the spirit, it is impacting the flesh, and as I care for the wounds in the flesh, it is reflecting and caring for the spirit. There is a direct care that is needed for both. But we cannot disregard that care on either side is impacting the other because it is connected in the soul. And thus I wanted to learn about the techniques, the practices of wound care, what they do and how they do it, how they assess wounds and how they determine what medicines they're going to use on the different types of wounds, and then translate that into a model of spiritual wound care. So I wanted to learn about what I call the I to the third power, I3. I wanted to learn about identification, intensification, and iomani, which is a Greek word for healing. In identification, I wanted to learn about their assessment techniques, which I really discovered that it isn't really the wound care therapist that really assesses and identifies the wounds. It's really the nurses. The nurses are caring for the patients, and either when a patient presents with a certain wound in the emergency area, or maybe a patient is in the hospital and they develop a pressure wound, when a wound is identified by the nurse, then they make a referral to the wound care specialist. So I wanted to see also, how they do the identification, but also how that practitioner of wound care does an assessment and the techniques that they use in caring for the wounds. I also wanted to understand intensification. I believe that the tending and the tools and the medicines and the skills are an intensification that cause pain in order to promote healing. One of my conversations with one of the physical wound care therapists, they told me that it hurt them to hurt the patient. They know that what they were doing was promoting healing, but seeing a patient feel pain, really no matter how much pain medicine they gave them in certain situations, and knowing that they're administering this pain was causing them pain, but it wasn't physical, but they were carrying that weight of pain. So there was an intensification. I wanted to see how they intensified the wound in the wound care process in order to promote that healing. And then I wanted to see iomani, how healing occurs. And we'll talk more about iomani a little later, but iomani, as I said, is a Greek word for healing. Then I wanted to take all this and I wanted to translate these findings into a language and a model of spiritual wound care with the goal of helping people journey, claim healing, and obtain soul wholeness. That is the entire purpose of this. Not just physically healed, not just spiritually healed, but soul wholeness. So during this research, I observed over 30 patients over the course of 13 months. I observed them from an inpatient and an outpatient wound care perspective. I observed the demographics, which you'll see on the screen, the demographics of the patients that I served. And then I observed them through silent observation, just being a shadow in the room, observing what the physical wound care therapist was doing. I would have interaction with the wound care therapist. I would reflect with them on what I observed and what they were doing to see if my observations were on point and to get insight from that wound care therapist. I would have interaction with the patient during the wound care treatment. I'd be involved in some way with the treatment, talking to them, asking them how they're experiencing it and what's going on for them and how they're doing. So I would be interacting with the patient. Sometimes it would be questions about what's going on physically. Sometimes I would be providing spiritual care as they were simultaneously receiving this physical wound care. And then I would interact with the patients pre or post their wound care treatment from a spiritual care perspective. So anytime there was an engagement beforehand, I might have known they were a wound care patient because there was a wound care list, and I may visit them before they were getting a treatment or after they were getting a treatment just to provide that care, that support, and see how they're journeying on this healing journey as they're physically being tended to. How is their spirit? How is their emotion? Especially when the wound healing may not progress as they had desired, or when it does progress, how are they feeling? So this was my methods of observing the physical wound care therapist in order to develop my model. So what is a wound? I'm pretty sure you know what a wound is, but I need you to hear this so that you understand what I was doing. That we know that a wound is an injury to the body's living tissue as a result of violence, surgery, accident, or injury, and typically results in the breaking of skin or tissue which does not heal or becomes chronic, leading to the damage of underlying tissue. And so the wound care professionals, these physical wound care therapists, they're providing wound care that is a medical practice intervention of tending to persistent wounds in order to prevent wound complication, reverse healthy tissue erosion, and create an environment for the promotion of healing. The one thing I always believe about these wounds is that wounds are obstacles and opportunities. They're an opportunity to identify strength and to overcome and to not overpower. It is strength to overcome the pain and to not overpower people, including oneself. Sometimes people overpower themselves because they're sick of dealing with the pain, and so they'll begin to do unhealthy self-medicating practices so that they don't have to deal with the pain, but they actually put themselves in a position of stagnating their healing process. So what is a spiritual wound? So a spiritual wound is a emotional or spiritual injury to the soul as a result of violence, trauma, accident, or ignoring that typically results in the breaking of the spirit, which does not heal and or becomes chronic, leading to the damage of one's humanness. This leads to encounters with existential limits. You see, physical wounds will prevent us from doing something. Physical wounds limit our physical capabilities, and we see ourselves still alive and trying to get back our physical capability. But when a spiritual wound manifests, when a spiritual wound comes into one's life, it causes one to see and to look at the limits of life and those existential limits, those things that are the threat to our human existence. Those things are death, meaning, aloneness, and freedom. Those are the existential limits that we face when we have a spiritual wound. And so when we have this spiritual wound, it can become a historical spiritual wound when it is not tended well. And see, a spiritual wound, a historical spiritual wound, is an emotional or spiritual injury to the soul as the result of violence, trauma, accident, ignoring, typically resulting in the breaking of the spirit, which does not heal, is not tended, festers, and becomes chronic, leading to the damage of one's humanness and diminishes one's soul wholeness. You see, I'm a promoter that soul wholeness is not the absence of woundedness. That being wounded does not diminish my wholeness, but when I am wounded, my wound is a part of my wholeness, but it diminishes my wholeness when I ignore my wound, do not properly tend to my wound, and my wound has a diminishing capacity on my abilities. So providing spiritual wound care, not spiritual care, but spiritual wound care. Spiritual wound care is a ministry practice intervention as identifying and intensifying persistent historical spiritual wounds and spiritual wounds in order to prevent wound complication, to reverse healthy soul erosion by creating an atmosphere and an environment for the promotion of healing and the fostering of healthy grieving for soul wholeness. Grieving, I believe, is the medicine tending to those spiritual wounds that promotes healing and promotes soul wholeness. So I believe that we cannot create, operate, or tend to the physical and the spiritual wounds mutually exclusive of one another and take no responsibility for the soul which we are impacting. When we tend to the physical but not the spiritual, we create opportunity for spiritual wounds that have manifested through the soul in the physical to resurface in the same place or in different ways. Do you know what this is? That's right, it's an iceberg. And one of the things about icebergs is that 70 to 80% of an iceberg is below the surface. You can't see it. And when we think about the wounds, even the physical wounds of a person, we often see the physical wound on the surface or we see the presentation, but there is a depth to the wound that we don't see unless we dig below the surface, unless we go below the surface, unless we go to the internal workings of the person. And to not do that would be to be ignoring potentially 70 to 80% of that which is causing harm to that patient or that person that needs to be tended. So let's look at this from a grief perspective. Elizabeth Kubler-Ross, she was one of the first to define stages of grief. And she defined the 5 stages of grief as denial, anger, depression, bargaining, and acceptance. These different 5 steps. Now, when I learned about grief, I felt like it was taught to me in this fashion, taught to me very linearly, that you have these different stages, and we go from an event of life such as death, and then we have anger and denial and depression and bargaining, and the whole goal is always focused on getting to acceptance. Not really thinking about the future birthdays, the Thanksgivings, the Christmases. It's all about getting to the place of acceptance. But I don't see grief that way. I see grief like this. I see grief in a circular coil fashion that has dramatic highs and dramatic lows in the beginning. And those highs and those lows don't go as high and they don't go as low as we continue on our grieving journey in a healthy manner. So we'll have a diagnosis and we'll go through all of those different stages of grief. And it doesn't matter the order, but we have to get to some place of acceptance with diagnosis if we're even going to get treatment. You don't get treatment if you haven't accepted that you have a diagnosis. You still may be wrestling with the diagnosis. You still may be angry with the diagnosis, but you have also achieved acceptance in order to get treatment. If the treatment doesn't work, there's a cycle that you'll go through of stages in that whole diagnosis working, not working. When a loved one passes away, there is a cycle of grief, anger, depression, bargaining, denial, acceptance. Doesn't matter the order, but it's all related just to that one situation that has to be processed and not just achieved acceptance for the entirety of the grieving journey, because when the next birthday comes up, there will be grieving. And there will be a process of grieving, and that grieving is not directly related to the death. It is related to the dreams that you had for that birthday. It is related to the time and the future hopes you had for Christmas and the plans you had for Thanksgiving that did not come to fruition because of an event in the past. I believe that this is the source of grief. I believe that this is where grief stems from. Not necessarily the event of life such as death, or even a diagnosis of a terminal illness. But I believe that the terminal illness or the death or some injury actually puts in jeopardy, in delay and or denial, the future dreams, plans, and hopes that we had. When someone's grandmother or mother or loved one gets sick and dies, they may begin to grieve thinking about graduation and them not being there. Or when they get married and they won't be there in the physical. Yes, there's a heaviness around the death. Yes, there is an emotion around the diagnosis. But I believe that at the core central of it is not just that event, that diagnosis, or that issue of death or issue of injury, but what that is putting at jeopardy. Those dreams, those hopes, and those plans. There's an event that causes and creates that jeopardy. And I believe that that is the source of grief. I believe that is also the source of grief. And I believe that that is what delineates between clinical situations and spiritual situations. One of the stages of grief, as you already saw and heard, is depression. And depression has become such a nasty word that people don't want to talk about or acknowledge because of the mental illness stigma of depression. But depression is a part of grief. But how do I know if depression is a part of grief? Or how do I know if there's this depression that I may have as some clinical issue? Well, the way I delineate it is that if your feelings of depression, if this patient, if this family member's feelings of feeling depressed have a source, then it's spiritual and emotional. If it doesn't have a source, then we look at it as in the clinical arena and they figure out what may be going on there. That when the loved one dies and you feel depressed, there's a source. When you're injured and you might not be able to play sports anymore, there's a source to the depression. Now, I believe that skipping stages of grieving, I believe that skipping or burying these stages can cause you to lose identification of the source of your grief. And by burying it and not tending it, it will become a historical spiritual wound that will render you emotionally unavailable in the present. It becomes a part of one's subconscious, and it binds them to the past. I believe that this is why it is so important and so vital that there's an elevation of assessment of the spiritual grieving, the healthiness and unhealthiness of the grieving of patients and families. One, to prevent unhealthy grieving from persisting and creating historical spiritual wounds that diminish their capacity. Number two, identifying someone with a diminished capacity so that there can be potentially some identification of a historical spiritual wound and a healthy grieving journey fostered for the promotion of soul wholeness. This is what I believe spiritual wound care is all about. Let me show you a case. This 30-year-old Hispanic male, he came into the ER and his foot had been, both of his feet actually had been crushed by a forklift. However, one foot had been hit, the other was smashed. It was flat, it was done. The other one had got hit, got poked in his ankle by a couple of screws, and it was dramatically swollen. When I walked into the ER, the doctor was in one of the observation rooms with the patient, and I go in, and the doctor is looking at the ankle, and he's pressing on the ankle of the patient. And he's asking, can you feel that? And the patient says, feel what? And there were these two holes. Like I said, his ankle had been punctured by some screws or something, and they were about the size of a straw. And they were on the outer side of his ankle. And so the doctor grabbed some metal tools and began to poke around in these holes in his ankle. And a little red stuff came out, and then the doctor began to press on this swollen ankle. And as he was squeezing, all of this coagulated gelatin-like stuff began to come out of his ankle. And I asked the doctor, I said, doctor, what are you doing? And the doctor says, I'm evacuating the hematoma. And as he continued to press, and more of this coagulated blood began to come out of the ankle, and the pressure was released in the hematoma, the patient began to say, hey, wait, what is that? Ouch! Because this hematoma had formed, and it caused a pressurization that he couldn't feel the pain. But when the hematoma was evacuated, then he could feel the pain of the injury. But you see, that pressurized hematoma and the diminishment of the pain was not how the patient was intended to live. The pressurization caused a delay in this patient bleeding out. The pressurization in the hematoma and the coagulated blood created a delay in the patient's death so that they could seek medical intervention. I believe that grief is the hematoma of the spirit, and that it must be evacuated to promote healing and to stave off infection. Because buried wounds may have no pain, but they have power, and they are diminishing, and they are infecting. And just because we can do things to self-medicate ourselves and to take away the pain, that doesn't help us promote healing. And it actually puts us in a situation that those wounds are festering, unchecked, unaware, and they are doing things to us, and they are killing us slowly from the inside out. Remember this? The iceberg, 70% below the surface. Well, that's what I call the grief hematoma, the emotional underload. It's where when we have families that may present or patients that may present, and we ask them how they're doing from an emotional perspective. How are you feeling? I'm fine, or we're okay, I'll be all right, I'm good, they're okay. All of these phrases that we can use to kind of distract and diminish from what's going on below the surface. And what Myron Madden said is that fear and anxiety are repressive energies. Sometimes we will suppress a thought or a feeling, which is an intentional action. We're afraid of people knowing, or afraid of exposure, or we're embarrassed because nobody wanted to hear us. But that fear and that anxiety and that practice of suppression can become repression, which is an automated reactive response to events of life that bury events, and we don't even consciously know that we're doing it. And these things become a part of our subconscious, and they become a part of the bottom of our iceberg. They become a part of our emotional underload. They become a part of our grief hematoma that weigh us down. Whether it's confusion, sometimes it even diminishes our joy. It buries our anger. It buries our peace. It buries that we're scared or relieved. But it's when we can talk about these things, it's when we can reveal these wounds, it's when we can evacuate the hematoma, that we can begin to create an atmosphere of healing, foster healthy grieving for the promotion of soul wholeness. When we don't evacuate the grief hematoma, our emotional investment, it's entangled in that buried wound. It renders us incapable, I use that word, incapable, of being fully emotionally available in the present. Why? Because it is taking emotional energy, fear and anxiety. It is taking energy to keep buried the things that we don't want to talk about, we don't want people to know about, we don't want to deal with. And if that is a part of me, it means that I'm not 100% available for the situation that's presently at hand. Can I give 100%? Sure I can. We can give 100% of what we have available. And sometimes when we think about our patients and our families and what we need from them, we need their participation. We need their buy-in. We need them to make decisions. Sometimes they're giving 100% of what they have, but what they have is only 30% of who they are. And they're more caught up in keeping buried the historical spiritual wounds. They're more caught up in keeping burying the hidden wholeness, their divine self, because of the woundedness that they began suppressing and repressing. Present life events, they begin to be processed and filtered through the lenses of these buried wounds, but they're not even consciously aware of it because these wounds are in their subconscious, not in their conscious mind. But they're processing things that nurses say to them, things that CECs say to them, things that doctors say to them, things that families say to them, things that chaplains say to them. And so how they respond, how they react, how they give back to us in interaction can help us assess. Are they present? Are they healthily present? Are they healthily engaged? Are they healthily grieving? And if not, make the referral for spiritual care. Or maybe they're having just an emotional need and you can sense that you want to know how to talk to your patient differently. Maybe that's where you reach out to the chaplain and you do a consult, gain some information and insight. Maybe it's something cultural going on with that patient. How do you approach the patient of a certain religious tradition, and how do you bond with that patient? You might want to consult when you see that you're not connecting. Maybe they haven't assumed their role. Maybe there's something that they need to deal with to help them assume the role, and maybe some things you can do to bond with them, but you might need a consult for that. But it's all about assessing the healthiness or the unhealthiness of their grieving and their being present. Let's look at another case. I had an 84-year-old Caucasian female who lived in a senior living community. She had 4 sons and a daughter, and she was involved in church, and she was involved in all kind of knitting and all kinds of group at her rehab, at her adult living facility. And she came in and she went back home. And she came back in a little later, and this time she wasn't going to be able to go back to her independent living in this senior living community. She was going to go and live with her son. I remember asking her, how she was feeling about that. And she says to me, how do I remain spiritually strong when my body becomes weak? She knew that her body was breaking down and her independence was, not going to be there anymore. She was going to go have to live with her son. And she says to me, I'm not sad. I'm not upset. She even said that her son made a room for her in his house, took down a door and put up a wall and wallpaper with flowers for her, and she loved flowers. And she said she cried at its beauty. So I asked her again, so how are you feeling about not going back to live by yourself, but going to live with your brother, your son? And she says, I'm not sad. And then she says to me vehemently, what, do you want me to be sad? She said, and I said, no, I don't want you to be anything. I said, I'm sad though. And she says, why are you sad? And I said, I'm sad because you can tell me what you're not, but you can't tell me what you are. And then she began to tell me that she had some anxiousness because she hadn't been in the same room with all 4 of her sons since she had been sick for over a year. She doesn't talk to her sons about her sickness. She eventually went to go live with him. She came back one time later. In that time, she stayed until she passed. But what made me sad was that she couldn't tell me what she was. She could only tell me what she wasn't. And in that moment, I did what I call an appropriate use of self. I have emotions from my own life, feelings from my own life, my family and work and all the things going on in the world. They cause emotions in me. But also I have emotions with my patients and my families and even with my staff members. And I can use those to connect and have empathy and compassion. And when she couldn't tell me what she was, I knew there was something in her that she didn't want to deal with. She didn't want to talk about. She didn't want to face. It's not my job to make her. I don't know what it is. But I can use myself to potentially make a connection with her, because one of the things that most people are afraid of is vulnerability. I believe when people don't talk and people don't share about themselves, it's not that they don't have anything to say. It's that no one is listening. Because often when people share with us their feelings, or they share with us how a situation is going, they get some of that old common world advice. Oh, pick yourself up by your bootstraps, or big boys and girls don't cry. And people begin to feel like their feelings, their human feelings, are diminished. So they stop sharing because they just keep getting advice and not companionship. And so I companioned with her by appropriately using myself, by just telling her how I was feeling in that moment. I'm sad. And I was. And then she began to talk about that which was on the bottom of her iceberg. Anxiousness with her sons and not having spoken with them about her diagnosis. She didn't have a grief community. She's grieving these changes of life. She's grieving moving from independent living to moving in with her son, and she can't even share with them the joys of it because she's not sharing with them her pains of it. It becomes very hard, difficult to impossible that when we share the joys but not the pains, it becomes a platitude. It becomes not an authentic, genuine sharing of oneself. Let's look at another case. I alone was left. I'll never forget this family. 59-year-old African-American male. He had a mother, some siblings, some nieces, and some nephews. And I visited the room, and on one visit, the brother and the sister were by the bedside. And I remember that they seemed a little anxious, a little quick with their answers. They were hiding something. And I asked them how many siblings there were, and they told me that there were 2 boys and 4 girls. And okay, I remember that. And on the very next day, I came back to the room, and there were more people there, and there was the 2 from the prior day, and there was a young man and a young woman, some other people in the room. And as I'm going around the room introducing myself, and I asked the young man by the bed, I said, how are you related? And he said, this is my uncle. And I said, oh, you must be so-and-so's son, because they told me that there were 2 brothers, 4 sisters. And when I said that, everybody's eyes in the room got those big cartoon bug eyes and looked at me, and I looked around the room and like, what just happened here? And the young man says, no, my father's dead. And I said, oh. I said, when did he die? He said 36 years ago. He was killed by gun violence. The family then, as we visited a little bit, asked me to pray for them, and I prayed, and I sang a song, and I shared with them a biblical story I call Thursday. And on the next day, a niece of the patient, one of his sister's daughters, came searching for me. And she found me, and she says to me, what did you say to my mother? I said, what do you mean? My mother came home talking about Thursday, something about Thursday, and she never talks like that, and she couldn't remember it all right, but what did you say? Because I've never seen my mother like that. And I retold the story to her that on Thursday, Jesus went into the garden to pray, and he knew Friday was coming. And in that garden on Thursday, he said 3 things, and he said 3 prayers. He says to his disciples, my soul is sorrowful, even until death. He says, the spirit is willing, but the flesh is weak. And then he prays a prayer 3 times, says, if this cup can pass from me, but not my will, thine will be done. And he's wrestling in his spirit and his flesh that he doesn't want to go. He wants to stay and continue to teach and continue to heal. He's fully human and he wants to say, but he's also in his spirit, he's fully divine, and he came to die for all of humanity, and he's ready to go. He's willing but weak. He wants to go, but he doesn't want to go. And he's sorrowful in his soul, and he says it to his disciples. And I told her the difference between us and Jesus, the difference between Jesus and her uncle. Jesus knew when his Friday was coming. And very often when we're in Thursday situations, we don't like to sit in the emotions. We don't like to sit in how we're feeling. We don't like to sit in the sorrowfulness and the suffering of Thursday, because we don't know when Friday's coming. But when you don't deal with your Thursday, you'll bring Thursday into Friday, and Friday will become unbearable. Not because God's grace is insufficient, but because he gives us grace on Friday for Friday. He doesn't give us grace on Friday for Friday, Thursday, Wednesday, and Tuesday. And this was the story I shared with the family because they hadn't handled their Thursdays healthily. They had been burying wounds of Thursday events of life over and over and over. The young man, the nephew whose father was killed 36 years ago, he even came to me and told me that he had been asking his aunts and uncles about his dad, but all they would tell him was to go look at picture books in the basement, but not to talk to them. But he was so thankful now for this insight. It even came out that that wasn't the only brother that had passed. They had had a brother who had died 1.5 years prior to cancer. They had had 2 other brothers who had died very young, less than 6 months old. And what had become of this family, because of a very tragic event of life, a Thursday event that was not processed healthily, every time someone in their family became gravely ill, they knew that they would not be able to talk about them again, because there were only 2 brothers and 4 sisters. And I know what you're saying. Yes, there's very often some people do only refer to those that are living and not those that are deceased. However, there is a very healthy way that I've seen people express it. There were 9 of us, but there's 7 living. Or I had 4 brothers, there's only 3 living. I have 1 brother left. I don't even know how many have passed. Very healthy ways. But when I ask about your siblings and you give me 2 and 4, when I say that you must be their uncle and there is an emotional reaction, there is an unhealthiness of burying. There is an unhealthiness of acknowledging the deceased. And they did not acknowledge the brother who had died 1 year ago. They didn't acknowledge the 2 other siblings that had died. And everyone was feeling a heaviness of knowing that their existential limits were being faced. They were facing their own mortality, knowing that when their day come to die, they would not be spoke of again in that family. And it just so happened, at the very end, when the patient passed and the family lost it, they did lose it. God made it where I was standing in the room at the foot of the bed with the last surviving brother. The mother had been taken out of the room. All of the sister siblings had left the room. And here I am standing with that brother as he looks at his deceased brother. I looked at him and I said, "You're the last brother left." And he looked at me with a shock and didn't say a word. I never saw that family again. I never heard of them again. I always prayed and I continue to pray and hope that those young children that were younger, they were in their 20s and 30s, that they would continue to seek healing and maybe be the catalyst in that family to create the atmosphere of healing, to foster healthy grieving, and to promote soul wholeness for that family. The whole thing was about the necessity of identifying that there was historical spiritual wound, identifying that they were unhealthily processing things and they were unhealthily self-medicating and unhealthily avoiding things, and then not avoid that, but raise awareness to that and give them tools to tend to their own wounds. Many of you do the same thing with your patients. You use a couple of tools in assessing patients physically. One that you probably are very familiar with that you use, or some of you, the nursing staff, is very familiar with, is called the FLAC, the Face, Legs, Arms, Cry Consolability Tool, where you assess nonverbal patients and signs of pain and ability to be consoled, and what is their face, their legs, their arms, their crying doing to assess their pain scale. This tool was developed at University of Michigan in Children's Hospital, primarily to be used for children that could not communicate their pain level. But it's now also used for adults and others who are not able to verbally communicate their pain so that you can assess. It's a tool that you use to assess the physical pain of somebody who cannot verbalize it. But I also have an issue with people being able to verbalize it, because there's another tool that's primarily used in cancer research and cancer treatment called the ESAS. It's the Edmonton System Assessment Scale. And this Edmonton scale, the ESAS is used to give to a patient typically after a chemo treatment. And it asks them a series of, I think 12, it was 10, they've expanded it to 12 questions. And the patient answers those questions. And after every chemo treatment, they get the same sheet, and they're going to graph how are they tracking along these treatments. Let me show you an example of an ESAS. So one of the things that you'll see about this ESAS tool that I found very interesting is that their pain and their depression and their anxieties, they're up and down, they're bobbing and weaving. But look at that line at the bottom, right at 0, spiritual pain. Their spiritual pain is at 0. I'm not saying that it's not. I'm not saying that it is. I say I wonder if people even really know how to assess their own spiritual pain. And I do find it interesting that when I researched some of the ESAS samples that were out there, a large majority of them, the spiritual care was 0 across the board. It never moves. So even sometimes patients' feedback, even them telling you what their pain is or their depression or their anxiety, they're not necessarily professionals in that. They're telling you something that they're feeling or experiencing, but even the interpretation of that leaves some gap. So I like to say, from the spiritual care perspective, what I've done since I shadowed physical wound care therapists and am translating it into a model of spiritual wound care, I also looked at these two tools, one that looks at nonverbal, non-able to communicate patients and assesses their pain, another one that gives a tool to a patient for them to answer and give back their information that may or may not be completely accurate. It's the patient's best guess or best communication. And take this information. I took these two tools, and I want to let you know that when it comes to spiritual care and spiritual wound care for assessing, that the future is flat. Flat is the faith and feelings language assessment tool. This is the FLAT tool. The FLAT is the acronym for the faith and feelings language assessment tool. There are 5 categories within this tool: faith, feelings, language, focus, and the 3T, which is the tense, tone, and time. During or post an interaction with a patient or family member, you would select items corresponding to what you've heard or what you've experienced in that encounter. Someone may say that they're anxious or that they're feeling anxious. That would be a feeling. Or you might be experiencing the presence of them or their responses to your questions in the context as being anxious. That would be under the 3T, the tense, tone, or time. They're presenting an anxiousness, healthy or unhealthy. You even have the flexibility in the tool in each section. If you are experiencing or have heard something that's not listed, you get to assess it as positive other, healthy, or negative other, unhealthy, and you can simply select that in the corresponding section, whether it's a faith, feeling, language, focus, or 3T. Now, the instructions will tell you to assess the healthy or unhealthy spiritual, emotional grief engagement while or after visiting with or observing a patient or family member select 1 to 5 identifiers in each of the categories. You don't have to select an item in each category. The more you select, the more detail you may provide. But you want to select one at least in a section, but you'd like to select a couple in each section. So, for example, if the patient was being strong but really avoiding their faith, you might select be strong because they were avoiding and not engaging. And maybe they were seeming a little depressed related to their diagnosis or related to their loved one being sick. Once you've selected your assessment identifiers per category, you would then scroll down to the bottom to see the score. Down in this section, there's a scale, the healthy, unhealthy score scale. You see that it goes from purple being healthy high all the way to red on red being unhealthy high. You also see a total score for the flat, which will color correspond to the overall healthiness. You also see each individual category's ranking of healthy, unhealthy below. Those color scales for the individual categories are different for the overall score, but you will be able to see, and you'll see more detail as we do some case studies a little later. In this area, right above, you will also find your buttons that you will clear. Here you see the Clear All button. This will clear all of the information that you have entered into the flat. Below your flat scale score, you have individual clear buttons. Let's say you selected an item in a certain section. You cannot deselect an item. You can reset that section without having to reset or clear the entire tool. So in this case, let's for example say we selected an item in the faith section and I wanted to clear the faith. You'll notice that what you have selected in the corresponding fields above displays in the bottom in the detail section. So if I wanted to clear the faith, what I've selected is highlighted in a color. I would just hit clear faith. And when I hit clear faith, it modifies it and it's gone. You'll also notice that the flat score scale also changed. So let's say, since we had originally selected be strong because they were avoiding, instead let's select be strong, they're being engaged in their grief, and let's say they have a healthy grief gap. I'll select that, and now we'll go down and see what that does to the score. Now we see that their score is a overall to -325. It's in the unhealthy range in the orange, but it also shows that they have a healthy faith with unhealthy feelings and unhealthy 3T, tense, tone, and time. So once again, below here you can see all of your detail. Here you have your individual buttons to clear each section if you need to clear one section or two sections only. Here you have your overall score. You have your scale and you have your Clear All button. And this is the flat tool. You will get access to your own test copy of this tool to use and hopefully provide feedback on its ability to help you identify and assess the healthy versus unhealthy grieving of patients and the families you serve. Let me give you an example. If you remember, I had the case a little bit earlier about the 84-year-old woman who was no longer to live independently. And she had come in on her first visit and I assessed her, and then when she came back and was no longer going to be able to go back to her independent living, the flat tool will show you how her grieving can be assessed as healthy or unhealthy. And I'm actually going to show you how the flat tool would have assessed her grief on her first visit, and then how it would have assessed her grief on the second visit, so that you can see that a patient can present with healthy or unhealthy grieving signs and symptoms on one day and may have healthy or unhealthy grieving signs and symptoms on another. So just because as the chaplain, as I may visit a patient or a family, they may exhibit healthy signs of grieving. But the next day or the next week, based upon treatment, based upon the plan of care, based upon health improvement or decline, the unhealthy grieving may begin to be displayed. But the chaplain may not be there to witness it because he just visited the patient 2 days ago. But there's a team who may see these patients and families more regularly who could make that assessment and could make that referral for support. But let's take a look at these cases, and I'm going to show you the flat tool. And I'll be right back. So if you recall, this 84-year-old woman, upon her first visit, let's assess it. When she came in, she talked about her faith and how she had experienced it over time. So we would select that she had accepted and experienced faith. And because she talked both about her faith from a spiritual perspective, but also the situation that she was in, the reality, she would have what I would call a healthy gap. She's walking in the valley in a healthy way. We'll select that too. When asking about her feelings, she just didn't have any. She said none at the time. So we'll select none in the feelings section. She didn't really have a language, but her focus was really on herself, that first visit, and her tense and tone were really about the present, her tense tone and time. So we'll select that. So this is on her first visit, and we'll look. She came in, according to the flat assessment tool, her grieving would be healthy, healthily engaged at a 2.5. In the green, healthy, and we see that she has high faith. But we also see that there is a healthy, but on a negative low side of the feelings, and she has a positive focus and a positive tense and tone. This still doesn't mean that we couldn't make a referral for support for her, maybe for her feelings, but you get an overall assessment, and then you get to see the individual categorizations that are going on there. So let's clear that, and let's see what she looks like when she came in on the second time. So the second time she came in, she was a little different. Now she had what I call a very unhealthy gap. Her being moved around, she was very consumed by the reality of what was going on. So we'll go with that she had the unhealthy gap perspective, very consumed. However, she had been grieving healthily the different events of life that were going on. While she was progressing towards death, she wasn't ignoring the reality of her emotions in that present. So I call that Thursday, and I'll call her Thursday to be healthy. She was feeling alone in her feelings, alone and anxious because she wasn't going to be going back to her friends, and she wasn't with her friends. So I'll mark anxious there, and alone, and aloneness for her feelings. Her language, though, she would say, I'm not. When I would ask her how she's feeling, she would say, I'm not sad, I'm not. So I'd mark, I am not. That was her language focus. She would talk about they are, her children, and she would talk about they. And she talked a lot about the situation and not about emotion. So we'll mark, she talked about it, but it was it, the situation, and it, not her emotions. Her focus on this second coming in was really about others and external. She had really lost a focus of herself. And in asking her how she was feeling, at least 2 to 3 times, she kept telling me how she wasn't, but she couldn't tell me what she was. I might consider this to be she was deflecting. So let's look at her score. Her score now, it's in the low unhealthy, a negative 2.5. And we can see that her faith has totally shifted. Her feelings are actually positive, but her language is down and her focus is down tremendously. And I remember at this point during this visit is when I said to her, "I'm sad." And she said to me, "Why are you sad?" And I said, "Because you can't tell me what you are. You can only tell me what you're not." And then she began to shift her focus. She went back to her being experienced as we shared and talking about her faith and being appreciative of going to her son's house, and that she was happy about it and sad about leaving the nursing home and all of her friends. So she was back to experiencing and having that healthy gap again of realizing the faith and belief she had, but also the reality and holding them in tension. That she was both sad and happy. And that fed right on into her feelings. Now you'll see there's a probing. So it took some probing to ask her how she was feeling and to get to that. So I'll mark that there was with probing, but she said that she was sad, and we'll mark that. And she was also happy, and we'll mark that. And I'll also say she said she was thankful. Now, thankful isn't one that's in here for the language, but I want to give her a healthy in her feeling thankful, so I would mark other on the positive side. She used language such as and I am, talking about herself and saying what she wanted. I'll mark those. She was back to talking about herself, her emotions, and her community, the one she was leaving and the one she was reconnecting to, leaving the nursing home and reconnecting with her children. And her tense tone and time. She was talking about the present, and she began to have hope again, and she began to have some optimism. I'd like to say that it was some of the appropriate use of self by my saying I'm sad, making myself vulnerable, putting emotions into the atmosphere, may have made her feel that her emotions and feelings wouldn't be alone. So let's see the shift. She was at a negative 2.25. And now she has shifted all the way to a very high, healthy purple of 8. Her faith is back. Her feelings are up. Everything is in the positive scale. And one thing to be noted is that there was nothing given to her but some emotion and space for her to reflect and for herself to be vulnerable and to get out that which was on her heart that she was afraid to share. And that's an example of how the flat tool works. Now let's go back and wrap this session up. So there's many takeaways. We'll cover more takeaways at the very, very end. But for right now, at the end of this first session, just want you to take this away and remember this. Assessing is always ongoing and continual. Things change and things manifest, so we're continually assessing. That physical and spiritual wound care ought not be mutually exclusive of one another. That the spiritual health can impact one's participation in the care of their physical health and vice versa. And lastly, remember, the future is flat. We'll see you in session 2.